Hello students, welcome to this session, chapter 13. Here we will see central line associated bloodstream infection. So what is the definition? It is development of bloodstream infection in hospitalized patient which is attributed to presence of central line as a source of infection and not associated with any other causes of the bloodstream infection. So it is totally of the infection of the central line after the insertion. So classification of central line can be, it is short term less than 72 hours, long term more than 72 hours, or according to the site it can be subclavian, femoral, internal, jugular, peripheral vein. Organisms causing central line associated infection, they can be cons, coagulase negative staphylococcus, Staphylococcus aureus, gram negative bacilli, in that it can be Klebsiella, Enterobacteria, then Pseudomonas, Acinetobacter, Citrobacter, and in fungi it is Candida. So cons and Acinetobacter, these two organisms, and Pseudomonas, these organisms are more commonly isolated. The route of entry in this, it can be through the patient's skin flora because of not taken proper aseptic precaution, or the contamination through healthcare worker because of the no proper hand hygiene, or hematogenously from the other focus of infection inside patient's body, or contamination of the device. So here you can see how patients with central lines get infected. So hand or glove touching the central line can be dirty, or medicines injected are not sterile, or skin where the line is placed can be dirty, that is aseptic precaution or cleaning is not done. So risk factors are device associated, patient associated, or healthcare worker associated. So in device associated, it is dependent on the duration. So longer the duration, more is the risk. Then site, femoral site is more risky, so subclavian site should be preferred. Then type, non-tunneled is more risky, multi-lumen more risky, and emergency situation is more risky than the elective situation. Patient related risk factors, so it is immunodeficiency, patient may be on immunosuppressant, long term steroids, or patient is having immunodeficiency disorders or higher antibiotic use. Patient may be having illness, any hematologic malignancy, burn, psoriasis, or any distant focus of the infection in the body. Healthcare worker associated factors, it can be poor hand hygiene, lack of infection control practice, that is ICP, skin antiseptic which is used. So alcohol is more causing infection than the chlorhexidine. So chlorhexidine is a preferred antiseptic. So now we will see what the diagnosis. So according to the device criteria, the catheter should be more than 2 calendar days. Clinical criteria, there should be symptoms like fever, chills, rigors, hypotension, bradycardia, apnea. Then catheter site, you will see erythema, that is redness, tenderness, warm, and swelling will be there. And sample taken, blood sample taken, it will show positive culture report. Now we will see insertion bundle and maintenance bundle. So what precaution should be taken while insertion, and then after that the maintenance. So in insertion, first is proper hand hygiene with all the steps, then sterility should be maintained, sterile device, and proper antiseptic is used with maximum PPE, that is gloves, mask, cap, apron. So all these things should be required. Then site, so subclavian site is choose because femoral is more having risk factor. Then in skin antiseptic, alcohol is more having risk factor, so chlorhexidine should be used. Then skin should be completely dry. Then semi-permeable dressing should be used, and date and time of insertion should be recorded. In maintenance bundle, daily care with hand hygiene and decontamination by alcohol should be done. Then local signs of infection like erythema, tenderness, warmth should be checked. Then change of dressing with 2% chlorhexidine should be done, and daily assessment of the removal of the catheter or central line should be seen. These are my references from which we can study. I hope this session you will find useful. Thank you.